Hi guys, welcome back to the channel. Okay, in last class we have started mixed odontogenic tumor, that is it has both epithelial and mesenchymal origin. Okay, so we have started with the first one, that is ameloblastic fibroma. We have dealt that it can be a hematomas proliferation or it can be a true neoplasm. Okay, it has an odontogenic epithelium and an ectomesenchyme or odontogenic mesenchyme resembling dental papilla. Okay, then we have seen its clinical features, that it is common in young adult and children, and it sometimes it is known as ameloblastic fibro-odontoma, and these all tumors are mainly an attempt or aborted attempt at tooth formation, and we have seen that is most common in posterior mandible. Okay, today we'll be dealing with this tumor only, about its radiographic features, differential diagnosis, histopath, and treatment planning. Okay, let's start. Radiographic tumor, it can be multilocular or unilocular. Okay, multilocular radiolucency with sclerotic margins, well demarcated border with bone. Okay, it has a sclerotic margin and a well demarcated border with bone. Unilocular is the feature of small tumor. Okay, it can be both multilocular and unilocular. Size vary from 1 to 8 centimeter. Can be associated or unassociated with the crown of impacted tooth. Okay, it can be associated or unassociated with the crown of the impacted tooth. Okay, it will displace developing teeth, resorb root, and displace the inferior alveolar canal. Okay, it will displace the developing teeth, will resorb the root, and will displace the inferior alveolar canal. Okay, coming to the differential diagnosis, if associated with tooth, the differential diagnosis is dentigenesis. If unassociated with tooth, the differential diagnosis can be OKC, central giant cell tumor, odontogenic myxoma, or central hemangioma. Okay, as it is associated and unassociated both with root, मतलब tooth के साथ associate भी हो सकता है ये tumor, or it can be unassociated. So differential diagnosis is based on that purpose or that criteria. If associated with tooth, then the differential diagnosis will be dentigenesis. If it is unassociated with tooth, the differential diagnosis will be OKC, central giant cell tumor, odontogenic myxoma, or central hemangioma. Okay, incisional biopsy for diagnostic confirmation and CT scan for determining the extent of mass and association with the developing tooth. Okay, incisional biopsy is for the diagnostic confirmation and CT scan for determining the extent of mass and association with developing tooth, if it is associated with developing tooth or not. Okay. Histopathology, the mesenchymal portion is myxoid in appearance and not collagenized. Okay, this is the characteristic feature of this tumor, ameloblastic fibroma, that the mesenchymal portion is myxoid, not collagenized. It is myxoid in appearance. Okay, myxoid in appearance. It resembles dental papilla. Okay, the epithelial portion is scattered in the form of island or strands. Okay, the mesenchymal component resemble dental papilla and the epithelial portion is scattered in the form of islands and strands. Okay, what are the treatment? Usually requires only enucleation and curettage to effect a cure. Encapsulated and non-invasive. Okay, as it is encapsulated and non-invasive tumor, the treatment of choice is enucleation and curettage. Nerve preservation is there as neural invasion is not there. Okay, mucosal closure, no drain or packing, only mucosal closure is there. As we are doing enucleation and curettage, no drain or packing is needed, only mucosal closure is there. Young patients, so regeneration in 9 to 12 months. Okay, osteogenesis or regeneration occurs as it is young patient, it occurs in 9 to 12 months. In cases of large tumor, dissection with 2.3 or 2.4 mm of reconstruction plate. अगर ट्यूमर बहुत लार्ज है एकदम रिसेक्शन चाहिए ही, तो वी do resection with 2.3 or 2.4 mm reconstruction plate. The plate should be removed after 1 year because नहीं तो फिर young patient है तो bone उस plate पे grow करने लग जाएगा, तो it should be removed after 1 year. Prognosis, low recurrence rate, and if recur, ameloblastic fibrosarcoma can be considered a malignant counterpart. Okay, that's all for today's class, and here we finish this tumor. Next class we'll starting with next mixed odontogenic tumor. Till then, like, share, subscribe and comment. Bye.